Hello, everyone. Welcome to Managing Heart Failure. Our friends are here from CardioSmart and the American College of Cardiology in the big city, Washington, D.C. My name is Jeff Davidson with Mended Hearts of Central Ohio. And what a great meeting topic. If you're not familiar with us, for 5 years now, every month we've had these incredible and diverse heart education meetings at the Ross Heart Hospital Auditorium. And every month we have a free meal and a validated parking pass and meetings on AFib and heart failure and chefs coming in and cooking meals for us. It's all about working together, staying heart healthy and not being surprised by a sudden cardiac event. Want to thank our sponsors who are, please visit the tables out in front. They make what we do possible. In addition to heart education meetings, we visit heart patients at the Ross and University Hospital East. And we have the largest chapter of Mended Hearts of 300 chapters in the country. A great organization. Also, there's a table up front. Our group has raised $209,000 in 12 months for the Courtney Williams Fund in Heart Failure Research. There's some information right outside the doors to your left. Of our 280 members, we lost 3 members. They were all in their 30s to heart failure or complications of heart failure. And so the fund we set up is at the Davis Heart and Lung Research Institute, and it's providing the funding to research all kinds of advances in heart failure. And I think Dr. Amani will probably speak about that. And as well as, I think Dr. Ray Hirschberger of Ohio State has a program called Idiopathic Cardiomyopathy, DCM, a program where he's looking for patients to do a study on a gene that could affect people in heart failure as well as their family. So let me just introduce Dr. Amani. He's an assistant professor of medicine, advanced heart failure, and cardiac transplant at OSU. Received his MD from Ohio State. He's written several journal articles and book chapters on topics such as, I'm a heart patient for 30 years, cardiac resynchronization therapy and venous thromboembolism. I mangled that probably. Also chronic heart failure. Dr. Amani specializes in advanced heart failure, cardiac transplantation, and other areas of mechanical heart support. And it's my pleasure to introduce Dr. Amani. Thank you.
Thank you, Jeff, very much. And thank all of you really for spending your evening with me here and us. And this is a great program. I see a lot of familiar faces here, which is nice. And that's a tribute to the Mended Hearts program and how well it's grown, but also very excited to see some new faces, so welcome. I want to talk a little bit today. It's going to be a little bit of a whirlwind tour about heart failure. Heart failure is an interesting topic, clearly. I specialize in it. But it's a group of syndromes, illnesses, symptoms, everything that kind of comes together, and we lump it under one umbrella called heart failure. And it can often be very difficult to grasp everything that goes into it. So today, hopefully, we'll have a chance to go over some of the major issues, including the causes, perhaps ways to prevent heart failure, and from there, really try to understand how we currently treat heart failure and things we're working on in the future to improve our treatments for everybody. Just for technical purposes, we do appreciate our sponsors, as Jeff said. Novartis was one of our major sponsors. I have no personal relationship with them, except when we do these educational activities. So these are the different topics that we're going to try to go over today. As I mentioned, It's a very broad area of cardiac illness and a very broad area of care that comes together under one name called heart failure. And that's a really scary name, heart failure, right? And we'll talk a little bit about that. But really, it should probably be renamed any number of things, cardiomyopathies or inefficiencies of the heart. But at the end of the day, pun completely intended, the heart is at the center of all of this. Statistically, heart failure is a very prevalent disease. There are 6 million people in the United States that are affected by some form of heart failure. The people that are more likely to develop heart failure are those, like all of us, who will get older. But those that have other illnesses or issues that increase the risk of a heart problem developing. Right now, obesity is one of the major ones that we face, but that isn't really the only one, and that isn't by itself. There are things like having had coronary artery disease, or kind of what we standardly call heart disease, people who have had heart attacks from that, people who have very high blood pressures that are difficult to control even with medications and other changes, people who are born with congenital heart issues, and many other conditions that affect or can affect other areas of the body but can also affect the heart. There are some forms of heart disease that turn into heart failure that can be inherited. So there's a genetic cause, as mentioned previously, and that's important, particularly when you're trying to counsel your own family members to seek health care, or if you're considering family planning issues for offspring and generations beyond. Interestingly, if we look at just general statistics, African Americans are at a higher risk, but that doesn't necessarily mean that they will get it, or that if you're not African American, you won't get it. And likewise, although those people who do tend to develop symptoms of heart failure at a younger age have more severe heart failure, that doesn't exclude those who get older who have heart failure, because they can also be very symptomatic. Women tend to present differently, as they do with many cardiac conditions, but when they do present, it is a little bit more severe when we see it in the office or in the hospital. The most important thing, though, I want to have you take away from this is these are statistics. And this is something that we think about when we think about the general population, and if I draw a big room together, or go into Ohio Stadium on a Saturday and look at all the people and say who is at risk. But this means nothing. If you have it, you're 100% of the statistic, and if you don't have it, you're 0%. So it's a little bit challenging to interpret statistics. We're all here today because we're either at risk, know people who have it, or are helping care for someone who does have heart failure. So we have a couple of patient testimonials here. I actually don't know these patients, but they were kind enough to lend their pictures and some testimonials to us. Brenda, she was 30 when she got diagnosed with heart failure. And we have a couple of people in the audience that were in similar situations, that were very young, and it's very hard to understand why, if you were otherwise healthy, like Lori here, who thought she was doing all the right things, but still developed heart failure symptoms, to have a physician come into the room at some point and say, you have heart failure. But if that happens, you're not alone. And as mentioned, about 6 million people in the United States have heart failure, and we get about 500,000 new patients to that every year. That's attributed to a lot of things: the increasing number of the population that's growing older, the number of illnesses, but really it's also a tribute to the fact that we're doing better at treating other conditions, so now heart failure becomes more of a condition as we grow older as a society. In the United States and in the developed world, coronary artery disease or heart attacks, the most common cause of heart failure, followed very closely by high blood pressure and similar issues. Worldwide, interestingly, it's from valve disorders still, but not in the United States. A very sobering statistic is that people who end up in the hospital because of heart failure have a high risk of going back to the hospital if we're not careful. As high as 1 in 3 patients who end up in the hospital will actually have to go back to the hospital at some point to be treated, and that is challenging. That's, nobody wants to be in a hospital, and I work in a hospital, and I don't want to see you in the hospital over and over again. I'd rather see you in the office. So we have to come up with ways to help treat you and a plan to help treat you, to help keep people out of the hospital, and that's our first goal when we see patients in that situation. Another extremely sobering statistic is that people with heart failure, you do have a lifelong illness once you are diagnosed. And in an unadjusted population, if I just take all statistics, people diagnosed with heart failure, about half of them are at risk of dying within the first 5 years. Now that's a statistic that can change dramatically person to person depending on the medications we utilize and the treatments we utilize to help and other things to treat associated illnesses. But it is something to keep in mind that this is a lifelong illness and requires lifelong changes and follow-up with a medical team to help treat. So what is heart failure? I mentioned all this stuff about heart failure. I mentioned that it's a group of disorders. But at the end of the day, it's an issue where the heart is not pumping efficiently. And so I tell, people ask why I got interested in heart failure. I have an engineering background, and so the heart is a mechanism, it pumps, and I tell people with heart failure, the good thing is I don't have to make a lot of decisions. It's either pumping well or it's not pumping well. So I don't have to worry about that. Now my goal is to try to make it pump better. But not pumping well can happen for two major reasons. One is that the heart becomes weak, and it doesn't have the strength to push blood out to the rest of your body. That's commonly referred to as systolic heart failure or heart failure with a reduced ejection fraction. We'll talk a little bit about ejection fraction or EF in a moment. So if that has been mentioned to you, this is an issue where the heart muscle has weakened and we're not pushing enough blood forward. However, there's another form of heart failure, and that's diastolic heart failure. And that's an issue where the heart squeezes just fine, but it doesn't relax and fill up with blood between each pump well enough to allow continuous flow of blood through your body. I use the analogy of a big balloon. And if you think about a big balloon that has to fill up so you can squeeze the air out, if you've got a stiff, thick balloon, think about how hard it is to blow that balloon up so you can push the same amount of air out. That's what happens to a heart with diastolic heart failure. It's stiff, it doesn't want to relax, and it makes it very difficult for the blood flow going forward. That causes blood flow backup and fluid backup, which leads to all the symptoms that heart failure patients have. Other terms that you'll hear from time to time, things like a dilated cardiomyopathy, again, fancy medical terms, but dilated meaning it's gotten enlarged, and cardiomyopathy, which means an illness of the heart tissue. And so here you see a normal heart that is shaped kind of in a conical looking shape, and a heart that has a cardiomyopathy that's sort of become more round as we go along. Now this is Ohio State, so we have to actually pare everything down to sports analogies. So a normal heart looks like a football. We like football around here. And not that we don't like basketball, but a heart that's been affected with a cardiomyopathy often starts to look like a basketball on a chest x-ray. And that's one of the first signs that we may look for when considering or when a patient comes in and we're worried about heart failure. So our goal is to actually take a basketball-shaped heart and make it look like a football again. And that's what we want to do with a lot of our medicines and our different treatments. So as mentioned, heart failure is a lifelong illness. Unfortunately, right now, we have no cure for heart failure. It's more similar to diabetes and high blood pressure. These are also disorders that come up that we treat and can treat successfully, but we don't cure at any point. It's not like an infection or a broken bone that sort of gets better and then we move on. Confusing, however, is we say, okay, heart failure is an incurable, lifelong illness, and people are labeled with heart failure, and yet we'll talk about people having heart failure and ending up in the hospital. Well, if we didn't take their heart failure away, why are we letting them leave the hospital? So we use heart failure episodes or acute heart failure episodes to represent those times where the symptoms get so bad that we need to use additional treatments that can only be delivered in a hospital. So that may be a time where some of you have been told, yes, you have heart failure, you had heart failure when you were in the hospital, and it's the underlying dysfunction or the underlying inefficiency of the heart that triggered that episode. Again, we mentioned the frequent hospital visits and the high likelihood of going back into the hospital. That's our job to try to help prevent that. So what is your heart doing? A little basic physiology. I did go to Ohio State Medical School. It was actually in this room about 14 years ago that I started med school, listening to a lecture about this, so it's fun to be turning around and giving this lecture. But the heart's basic job is to pump blood to the rest of the body. And the blood provides nutrients and oxygen. It's the way our body gets energy. And it is how we supply our general vitality, right? And this is why poets and songwriters and philosophers for years have always pined away about the heart. Well, it is important. It is how we get our life source. That's coming from a cardiologist. If the heart doesn't pump well, you don't get blood flow forward, which means you're depriving your body of energy and oxygen, and this is why muscles become tired, people feel fatigued, you can't do the things you were once doing. But likewise, or in addition, the heart doesn't pump the fluid forward means it's doing something, it's backing up. And the analogy I often use is that the drain at the bottom of your kitchen sink is a way to move fluid. And if that isn't draining well, it may be clogged, it may have an issue, pipes are rusty, that fluid builds back up into the sink. In your body, the fluid will build back up into your lungs, it'll get into your stomach, into your legs, we get swelling, we get shortness of breath, we feel full or distended, bloated. These are the things that happen because of extra fluid backing up. So again, the goal, make fluid go forward, relieve these congestive symptoms, as we call them, and increase the energy flow to the rest of your body. So one of the main descriptive terms that you'll often hear medical personnel describe is the ejection fraction. What is the ejection fraction? So it's the amount of blood that squeezes from the main pumping chamber of your heart, the left ventricle, to the rest of your body. Now, interestingly, normal is not 100%. It's usually about 60% to ballpark, and that can change due to the underlying illnesses. So people with heart failure with reduced ejection fraction will have EFs that are a little bit lower versus those that have preserved ejection fractions, which are in the more normal range. Either way, to some extent, it doesn't matter because we're still dealing with the inefficiency of the heart, but it does change a little bit of the medical therapies we need to give you to help treat the underlying heart failure. So here's a summary of our ejection fractions. In EF of 55 to 70, any of that can be considered normal depending on which resource you look at. 35 or 36 to 49%, mildly reduced, and then that less than 35% is a more significant reduction in ejection fraction. Again, I repeat though, the number is one thing and how patients are doing is very different. And people with an ejection fraction that is low can actually feel very, very well once they're on good medical therapy and they're doing all the right things. And likewise, people with normal ejection fractions can sometimes feel poorly. So symptoms, much more important than just the number. And how we assess that is something called a functional status. Again, that can be as simple as, what did you do today and how much can you do? And how is that different from what you normally do? And these are important questions and important answers when you're talking to your care team because it, again, helps guide how much therapy we should give or when we should potentially peel back some therapies. So for patients who have heart failure and family members who are helping care for patients with heart failure, if you're going in to see your physician, think about those things. That will help us a lot when you come to your visit. If you tell us, well, here's what I'm doing in the last couple of days, couple of weeks, and here's how it's different from what I've normally been able to do. Because then that tells me when I see you, it's time to do something a little bit differently if we're going in the wrong direction. So how did people end up with heart failure? And that's the first question we have to ask when somebody new comes into my office. How did you get heart failure? It's complex. There are many reasons as mentioned. And you see here a table that has just some of those reasons listed. We talked about heart disease and heart attacks and coronary disease, blood pressure, diabetes, genetic conditions, as mentioned. So there are some that can be passed along generation to generation. Other illnesses with other organs, kidney issues that can cause heart problems down the line. Infections, there are some particular types of infections that can do it. Right now, Zika is not one of them, but we never know. Things do change as we learn more. And I left other things out. There are conditions like amyloidosis, sarcoidosis. There are many things that can affect the heart, and that's one of the first things that we will try to do. We will try to help you understand why your heart failure developed. And that can involve a variety of testing. It can involve getting old test results and blood work. It's also a careful history, family history, all of those things that help us understand. And so when you come in for the first time and you're undergoing all of these tests, that's what we're trying to do. Because treating the heart is only good if we can treat some of the conditions that cause the heart failure as well. So how do you know if you have heart failure? Or how do you know if your heart failure is becoming worse? There are many signs and symptoms and many ways for patients to present. And it's not always obvious. So again, we asked Brenda here, and Brenda tells us, she was having trouble breathing, and she just thought it was bronchitis or, the cold or allergies. And certainly people are allowed to get colds and allergies, but when it starts to deviate from that pattern, it lingers for a long time, or it's really severe, it's worse than any cold you've had before, that's time to seek some medical attention, because it may not be just the heart, but there's something else going on, and we do want to try to help find out what that is. So really, you are your own best judge, or those around you are the best judge. If they tell you something isn't right, listen to that. And if you can't figure it out, seek some medical help. We'll try to help you. There are some signs and symptoms that are more common than not, and so we use the term FACEs to try to help us remember what those are. The F is for fatigue, a constant lack of energy, out of proportion. You may have had a late night, you may be up late Saturday watching the game, Sunday you're tired, that's a little bit different. But fatigue that lingers and you're getting a good night's sleep and you still can't get up and go. Again, we need to look into that. That leads to people having limited activities. If you're not doing some of the things that you enjoyed previously because you just don't feel like you can, that's a sign that your heart failure may be getting worse. Chest congestion, so that feeling of something in your lungs. You're coughing a lot. It could be a white stuff coming up. When you lay back, it feels like there's fluid in your lungs. That could be a sign. You start to swell in your ankles, your legs, your fingers start to get puffy. People's stomach, and this is an interesting one because we talk a lot about swelling, but many people, particularly men, will actually hide their fluid in their stomach long before it shows up in their legs. So that swelling can also be in the stomach where you can't eat as well, or you're hungry and you start eating and you get full very, very quickly. There's only so much space in there, and if fluid's taken up most of it, you're not going to be able to get food in there. And shortness of breath is the big one, and that's universally something that's worrisome. If you really can't breathe and you can't complete sentences, or somebody says, you just look terrible, you just climbed up the stairs of this auditorium and you're huffing and puffing at the top, that may be a sign that things are going the wrong way, and we want to change treatment for that. Mentioned the lack of appetite, nausea, vomiting, heart rate, and obviously irregular heart rhythms, palpitations, things pounding in your chest pain or chest pressure, very serious signs or symptoms. Go ahead and seek medical attention, or at least call one of your medical providers to get some advice. There are red flags. There are things that we want to be very cognizant about and treat early. Another one that you'll hear us talk a lot about is weight. And that's our way of trying to monitor how much fluid somebody has. And when weight starts to change quickly, It's rarely what you're eating, unless you're going out and eating a huge steak every night. You're not putting that much food into you to gain 6, 7 pounds in a very quick period of time, 24, 48 hours. That's often a sign of fluid coming on very quickly. Call early, because an early call may allow us to use medication changes that'll help keep you out of the hospital. If that persists too long, then we're stuck coming into the hospital using intravenous medications to help get that fluid off. Other signs and symptoms, this is more of a long-term issue. Weight loss that is muscle weight loss. People are getting weak. Cachectic is the term we use medically. That can happen because you're not providing the nutrients to the rest of your body from your heart the way we need it to. Remember the chest pressure and inability to lay flat. So again, if somebody at home says, why are you not sleeping in your bedroom anymore because you're always falling asleep in the recliner, and you think it's just more comfortable because you're sitting upright a little bit, that may be a sign that we're holding on to fluid. That's that drain in the kitchen sink that's starting to back up into your lungs. We want to know about that. So a couple other things. Again, we asked Lori here, and she says knowing the symptoms are most important, and I completely agree with that. Again, you know your body better than anybody. All the medical school and medical training in the world doesn't override what you know about you. And we want to take that seriously. As long as you are reporting things to us, we will be able to better help you. Now, when you do come in, what are we going to do? We're going to listen to you first, your story. You're going to tell us how things are going. And then we're going to listen to your heart and your lungs. And there are things that we can hear. Sometimes you can hear the fluid in the lungs. You'll hear physicians and other medical providers tell you that. Sometimes we can hear the irregular heart rhythms or heart murmurs that have changed. Those can all be signs that something different is happening. We're going to push on your belly. We're going to look at your neck. This is one of our favorite things to do. In Halloween time, it's appropriate to talk about staring at a neck like a vampire, but what we're actually doing is trying to measure the extra fluid that you may have on board based on your jugular vein here. We'll push on your belly, we'll push on your ankles, we'll get a sense of what's going on. We'll check vital signs like blood pressure, your heart rate, your oxygen levels, and we piece all of that together, again, to either confirm that this is from the heart or maybe say, you know what, this time, thankfully, it isn't. Doesn't mean something else isn't going on, but at least we can start to treat that other stuff and feel better that it's not your heart. Let's assume more times than not it is your heart. It gives us an option to start making treatment changes there. If it's a severe case or the first episode, we're going to need a little bit more information. We're going to check blood work. We want to know how your kidneys are functioning, your liver is functioning. We're going to look at your potassium levels. Another medical test that many of you may have heard is something called a BNP, or an NT-proBNP. That's an interesting chemical that our body produces in response to extra fluid. And when that number goes up, it can correlate with extra fluid being on board. Now, it's not the only way and should never be the only way to diagnose it, but it really does help us a lot, particularly to know how much or how severe something is happening. So we'll track BNP levels. Chest x-rays, EKGs, again, help us really see what's happening internally. At some point, if you're a heart patient, you are going to get, if you haven't already, an ultrasound of your heart. We call it an echocardiogram. Similar technology to what they use for babies, but we can't call it a fetal ultrasound, so we call it an echocardiogram. And we're going to look at the heart itself, and that tells us that ejection fraction number. It gives us some more information about how strong the heart is squeezing and how well it's relaxing for the diastolic portion. We can look at heart valves. We can see if they're stiff, if they're leaky. We can see if certain areas of the heart are not working as well as others. And if that's the case, we may move on to a stress test or an angiogram, a heart catheterization, to better see if there's a blockage causing problems. So if there's a blockage, the nice thing is fixing the blockage can often help your heart failure symptoms tremendously. That's my job. That's what we do when you come in. But that's only part of the story, because then we got to turn care over to you. And this is probably the most important part, is the transition from an office or a hospital to home, because that's the key to keeping a successful intervention successful. So long term, you have to become a part of your own health care. And being here is a good step, starting to understand the medical background for it, understanding what to look for, and then keeping track of that and keeping your medical team informed of how things are going. Once you've been diagnosed, things are going to be a little bit different than they were before. Your energy levels aren't going to come back right away if we've given you treatment. It can often take months, weeks, and it may never come back all the way to the way it was at one point, but hopefully it should come back to a point that you can enjoy life and have a good quality of life. Patience is important. Again, not an overnight thing. And there are ways that we can help and that you can help increase exercise and increase stamina as you go along. But it's going to involve lifestyle changes too. Diet, exercise, all those really boring things that we tell you, they are important. And the better you can do with them at home, the better you will do in the long term. And, you're a heart patient now. You have to know that, and don't be afraid to let other people know it if it's appropriate. Expectations, and this happens a lot if you have grandchildren at home. You can't be picking them up and playing with them all the time if you're tired, so pace yourself. Know that, and let them know that too. What treatment options do we have? Well, treatment really starts with understanding who's involved with the treatment team. Again, sports analogies. Ohio State, heart failure management is a team sport. And these are some of the team members on that. The patient, you are the center of this team. You are the quarterback. You have to know what everybody else is doing, and you have to be willing to call the plays and call an audible if time comes. The caregivers, those around you, your family, your friends, your support system, very, very important. They're going through some of this with you too. They're probably going to have to learn some patience, but they're also going to be able to help you as you learn to live with your new normal. So keep them informed and listen to them. And also understand that it causes some stress on them because it doesn't work as a team if there's conflict based on that. Healthcare professionals, that's the physicians, nurse practitioners, PAs, nurses. When you come to the office, when you come to the hospital, we're involved. When you're calling on the phone, we're involved to help relay messages back and forth. Don't forget about pharmacists. They're a wonderful source of information because it turns out you're probably going to be on a lot of medications. And they're very good at helping you understand where interactions may be happening, side effects may be happening. So when you go pick up the pill bottle, they're going to ask you, do you have any questions? Definitely ask them if you have questions. They're a great source of information. When possible, we try to get patients to see a nutritionist to understand the importance of diet in the control of your heart failure. Exercise physiologists, if you go to cardiac rehab, they're going to help get your strength back, get your endurance back. Again, not an inclusive list, but you can see this becomes a very big team and many, many people involved. So general treatment principles. So let's get to some of the specifics about how we treat heart failure. Again, if the issue is we're limiting a patient's ability to perform what they need to do, we want to make that better. So you're trying to move and you can't because we have a lot of stuff stacked on this cart. The heart's tired, it doesn't want to move, and it's got a lot of extra stuff to move because there's probably a lot of extra fluid on board and higher blood pressures to deal with in some patients and other issues that we're fighting against. So what do we want to do? Well, we want to reduce the number of stacks on the wagon so that the wagon works or is easier to pull along. You can see our buddy here is starting to move along a little bit better. We want to give medications that increase the heart's strength, and some ways to do it, again, is to limit the speed or limit the amount of energy that's being used per beat so that the long-term efficiency gets better. And now you can move along at a good, steady pace without struggling. The heart's efficiency goes up, and now you're skating along. So this is what we're trying to do. That goes along with some of the lifestyle changes and some of the other things that we do. Now, there are some more advanced things for some people when we get to it. There are implantable devices that we can use, defibrillators, pacemakers, things that help that efficiency. What I like, transplants and heart pumps, but that's not for everybody. Certain patients, when we want to cut you open and do something, fixing heart valves or fixing blockages. But ultimately, there are medications that are still going to be the cornerstone. So some of the specific medicines that you may have heard about, beta blockers. Beta blockers are a type of medication that help reduce the amount of energy your heart requires per squeeze. That improves its efficiency. ACE inhibitors, angiotensin receptor blockers, a new class of medications called ARNIs. These are all meant to help reduce the wagon load. They take some of the burden off of the heart. They can allow the heart to heal or improve, and they reduce your blood pressure. So these are medicines that you may also be on. There are other pills like water pills to reduce the amount of actual fluid being pushed around. So Lasix is a very common one. Torsemide or Demodex, there are different names for these, but these are medicines that you're probably familiar with as well. Spironolactone or eplerenone are medications that help some of the hormonal imbalances that happen. I'm not talking about the hormones that make you moody, but I'm talking about the ones that your body produces in response to the lack of blood flow that then cause other things to start to change. So those are some of the major medications we use. There's another class called ivabradine. It reduces heart rate, digoxin. These are all combinations. The good is these medicines can all work together to help when it's appropriate to use them. The bad is it's a lot of medicines. And trust us, we don't like giving more and more medicines. It's hard for you to take. It's painful for us to watch. So we're not cruel people every time we put a new medicine on board. But there has been scientific data to prove that these combinations work well. If it's correct for you, we want to give you every chance to make your heart as strong as possible. I mentioned the medications we use to treat some of the associated conditions, so aspirin, blood thinners like warfarin. These all come into play, and unfortunately, if you count up the medications, this can be anywhere from 3 medicines to 25 medicines. It's a lot of medications involved. We understand that that is challenging, but again, these are proven to help. But there are things that you can do as well. So getting your exercise is good. Eating a healthy diet, make smart choices. Both what you put on your plate and how much you put on the plate is important. And this is where a nutritionist can be very important to tailor. No 2 patients are the same. Your specific diet plan can be tailored to give you the best chance to do well. Basic principles, sodium. Sodium or salt causes your body to hold on to extra fluid. If we're trying to get rid of the fluid to make it easier on your heart, we don't want to push on the gas and brake pedal at the same time. So putting extra fluid in isn't helping. So everyone should nervously look at their bottle of water in front of them now and say, okay, how many ounces is that? And you've probably been given a goal at some point. And you want to keep that in mind, and it is important. Oftentimes, if we can do a good job reducing the amount of sodium and reducing the amount of fluid going into you, we can actually cut back on the water pills because we don't have to take as much out of you. And then you're not running to the bathroom all the time. So there is some benefit to this. It is good, it is important, it works. For some people, losing weight will help. The analogy I like to use there is if you have got a big pickup truck and I've got an engine, a little teeny scooter engine in there, it's going to have a hard time powering that big truck. Reducing the weight helps match the output of your heart to the needs of your body. All the fun stuff, don't do it. But you have to do it in moderation if it's appropriate. Alcohol is a fluid first and foremost, but it can affect your medications, it can affect your liver, and it can affect your heart. So you have to think about that as well. Tobacco use, we're always going to say that's a bad idea because that directly affects your heart. There are other things like excess caffeine, and I like my coffee just as much as anybody, but we all have to limit that. So keep those in mind, and if you have questions, bring those up at your appointment. In fact, maybe one of your appointments should be dedicated just to what can I do at home to help make smarter choices. So I think I already touched on this. Sodium is a component of salt. It's out there. And it's never really the salt that anybody adds. I mean, we all have salt shakers, and some people throw them away or say, I never touch the salt shaker. That's good first step. But it's the salt that comes hidden in the foods already that we have to be careful about. Processed foods, such as frozen frozen packaged meals, canned foods, soups, these can all have a high degree of sodium in it. Learning to read the labels is key to being successful in managing your heart failure. Now, questions I get asked a lot, well, what about sea salt? Sea salt's better, or pink Himalayan salt. That sounds pretty good. It's still salt. One of my mentors told me the only difference between table salt and sea salt is sea salt has fish poop in it. So think about that one. For most people, we're going to recommend salt between 1,500 milligrams a day to 2,000 milligrams a day. The average diet in this part of the country probably has about 6,000 milligrams of salt. So you really have to think about it. It is doable. Just being smart and recognizing sources of sodium is the first way to really start to cut out sodium. So here's a little animation. You start to absorb up fluid like the sponge here. The fluid comes up, then your blood pressure goes up, and your heart failure symptoms get worse. And then we're trying to fight an uphill battle. We're trying to reverse processes. So here's some, just samples. Again, this should be tailored to you and what you need with some input and guidance. Alternates, so okay, salt does taste good when you put it on food, I'll give you that, but there are ways to get good tasting food without using salt. So a couple of examples up there of alternate seasonings, and there are salt substitutes available. Again, check with your medical team because that isn't right for everybody either, but a salt substitute may be a good option. So I'm going to harp on this. It's important, right? It's good. So even small levels of salt, what you think is small, can add up very, very quickly. So here are some of the common foods that have a lot of sodium in it. Ones that people don't realize, breads sometimes have it. Some of the salad dressings that we have, think, okay, salad's good, that's healthy for me, and then you put the salad dressing on and we may lose some of that benefit. Obvious ones like pretzels that are sprinkled with salt. If you see it, it's probably a lot. But certain other things, fast foods and food, as a rule of thumb, if somebody else is making it and you don't know, you probably don't know, and it may have more sodium than you think. The good news about that is many of the restaurants do have nutritional information available, so ask for it. Look at it and use that to help make smarter choices. Here's a label. Look for sodium on it, and it's often listed as milligrams. But the trick to this is that they are going to give you milligrams per serving. And then if you look, you're going to see how many servings are in a container, in the bag, in the can, or how many are you going to put. So what's a typical serving size? So that's usually listed up here at the top. It'll say serving size up here is a half cup, and in this particular one, 4 servings in the container. So now you have to take your 300 milligrams of sodium and multiply it by 4. So you're actually getting 1,200. And if you're on a 1,500 milligram sodium guide and restricted diet, you're getting almost all of your daily sodium in this one take. So it's a little bit of math too. For those that have smartphones, there are apps out there that really help guide this, nutrition-based apps where you can actually go to the grocery store and scan a label or scan a product, and it'll give you all of the information, and you can store that to help you plan your grocery lists and your meals. Whatever system you come up with, use it. It's good. It's important. So I mentioned, that when you're thinking about foods, here's some guidelines on those types of foods that if you're trying to make smart choices, less than 140 milligrams in that particular food or serving, that's good. When you're getting above 400, be careful. Again, it doesn't mean you can't have them, but you have to factor that in and cut back somewhere else in the day. So other things, medical care. Follow-up visits are important. We do, like I said, I like to see you in the office much more than I like to see you in the hospital. So if we can see you in the office periodically, keep on top of things, and be proactive, we can hopefully keep you out of the hospital. It gives us a chance to do risk factor modification and screen for some of the other things that we normally do for people who are at risk, for example, cholesterol, blood sugar screenings. These are all very important. Flu vaccines are important. Pneumonia vaccines are important. Again, they may not be for everybody. Talk to your provider. If they're right for you, as a whole, typically recommended in a heart failure situation. Other illnesses that people get usually increase the demand on the heart. So you're increasing the demand on a heart that is already a little bit inefficient. You're going to have a harder time fighting that infection, fighting off that pneumonia, and it could make things a longer course or a more serious course. So trying to prevent those things important. So I mentioned here referral to cardiac rehab. They're a great source. They can help with the exercise endurance, but it's not just exercise at cardiac rehab. They often have many other available resources. They'll have a nutritionist, they'll have education, places to reinforce or ask questions if you forget. A lot of ways that cardiac rehab can help. So if you've been referred to it or you think that might be something you're interested in, definitely talk to somebody. It's a wonderful, wonderful way to help get people to do better. We have some newer devices too where we can help monitor things at home. For people who have pacemakers and defibrillators, sometimes you get that big box that sits on the side of your bed and it'll periodically query what's happening in your pacemaker defibrillator and send us information so we can monitor for irregular heart rhythms. Some of them help us monitor for fluid levels. There are newer devices that we can put into some people that directly monitor fluid levels and transmit that information to us. We're not trying to be creepy and watch your every movement, but we're trying to help keep you doing well. What we have learned is that oftentimes the internal changes can happen 7 to 10 days before the symptoms even show up. And that gives us a good window to try to actually make a change early and prevent a problem. So medications, I say here, they said the average is over 11. I think I talked a little bit about that. Get rid of fluid, decrease the strain, repair the heart for some people, all potential and important ways to get doing better. Mentioned up here the CardioSmart, because they're helping us today. So the CardioSmart app is probably a great single resource app. Available, I think, in both Apple and the Android stores now. If you've got that smartphone, or if not, there's a website that I'll post here at the end to direct yourself to get more information. Medications do have side effects. We do realize this. Make sure you're communicating back with us, because some of those side effects we can help with. And it's not always give you another medicine to cover up your side effect, although sometimes we do that. But we can adjust the doses, we can help adjust the timing, because it may be an interaction with one of your other medicines. You telling us is the most important part. And remember, I'm not treating numbers, I'm not treating lists, I'm treating you, so your symptoms are going to be important to help us tailor to make it the best for you. We want you to do well. And the pharmacists are very important. I mentioned that as well. Medicines can be expensive. We realize that as well. Sometimes that's a challenge, to say the least. But there may be ways to help with some of that, or help with some of the medical costs associated. Make sure you're keeping us up to date on that too, because we want to put you in touch with the right resources, or make sure that you can make the best decisions you can regarding the cost of all of this. Oh, here we go. Here are the actual medications. I jumped the gun on it, but a quick summary of diuretics, the water pills as we call them, the ACE inhibitors, ARBs, ARNIs as a group, beta blockers, aldosterone antagonist, digoxin. So these are just some of the medicines. Again, there are specific medications we will use for more specific conditions as well. At some point, some patients are going to require a little bit more than medicines, and these are some of the devices that you may hear about. Procedures can involve pacemakers and defibrillators. The difference, because you'll hear people use both terms, a defibrillator is like a guard. It stands over your heart and watches your heart for a dangerous heart rhythm. And if your heart goes into that dangerous heart rhythm, it's going to try to get your heart out of it. It has special ways to maybe do some internal pacing for it, or it may have to shock your heart. In the right condition, that's a life-saving intervention. So it's a guard, it's a watchman for your heart to help save your heart from a regular heart rhythm and save your life. Pacemakers actually deliver an electric current to the heart to try to help the timing of the beats. So perhaps your heart goes too slowly or goes slowly and irregularly at a certain point. We want to use a pacemaker to make that regular and at the correct rate for what you are doing. And they have activity sensors built in so they know when to increase the heart rate or reduce the heart rate. Sometimes the electrical system is different to one part of your heart or the other. We want to resynchronize that together. So you hear the term cardiac resynchronization therapy, or CRT. That is a special type of pacemaker that's trying to reset the timing of the different chambers of your heart to pump more efficiently. So here's the defibrillator. It looks a lot like a pacemaker, so it's easy to get confused. We understand that, especially because you can get both in one device. So you can get a pacemaker defibrillator together. Important that you ask and understand, what are you putting in me? What is it supposed to do? What am I supposed to do for it? Most of the time it's automatic. Sometimes you have to hit a button for that thing on the side of your bed to get the reports back and forth so we can get the information. We want to treat other conditions. Sleep apnea, for example. Sleep apnea is an inefficient breathing at night. When I bring up sleep apnea, most people first thing to tell me is, I sleep fine, doc, that's fine. I said, it's not how you're sleeping, it's the way in which you are sleeping. And I put the cards up here because I already have odds on my side. About 2 out of 3 heart patients and heart failure patients probably have some degree of sleep apnea. So I'm already playing with house money on this one. So I'm going to bet you have sleep apnea when you walk in the door, and you're going to have to prove me wrong. But what's happening with sleep apnea? Your lungs are not exchanging oxygen efficiently. And at night, when you're trying to rest, you're not getting the rest because the rest of your body is working harder to overcome that inefficient oxygen exchange. That causes adrenaline levels to go up. Adrenaline is good if you're running away from a bear. It's not good at night when you're trying to sleep. So this is why we want to treat it, because it actually helps the heart heal at night. It reduces those adrenaline levels, and that increases the efficiency. People do feel better. Sleep apnea treatment, like all of our treatments, can be challenging. Not everybody needs a mask, CPAP or BiPAP therapy. Those who are prescribed, sometimes it is challenging to wear. We understand that. But again, knowing it is the first step to trying to figure out the best way to treat it, and that'll often involve a sleep specialist in our care team. The heart failure is difficult to control even with all of that. Then we start to think about your more advanced things. For some people, heart transplantation is an option. Important to know about heart transplant, it is not a cure for your heart failure because transplant has its own challenges. And you think the heart failure patients have a lot of medications. Ask a transplant patient, they have a lot of medications. Left ventricular assist devices, so these are heart pumps. So if the issue is that the heart isn't pumping enough blood to the rest of the body, for some people we can actually put a mechanical pump into them to pump blood to the rest of the body. That is a surgery, so it involves a lot of recovery time and the risks that come with surgery. So again, we don't want to jump and do this for everybody, but in the right situation, it can be a good thing. Sometimes we prescribe inotropes. This is a type of medication that's an intravenous medicine, and you go home with a special type of IV line, often called a PICC line, and to it attached is a little pump like an insulin pump, and medication goes through that 24/7 to help increase the amount of blood flow going through your heart. These are specialized things. These will happen hopefully only after all of the other things are no longer working. But if you are referred for something like this, it's because we want to make you feel better, and these can make you feel better. In some cases, cases, and I talked about heart failure being an incurable disease, we do get to a point where we have to face the reality that the heart is going to get a little bit worse despite these things. And then we have to think about some of the additional things that go along with treating a long-term incurable disease. For some people, hospice starts to come into that discussion, and that's appropriate at the right time and the right place, but is not necessarily appropriate for everybody. But if you hear that, I think it's appropriate to be concerned. Ask again, am I really at that level? Listen to the answer, have an honest discussion, because again, if it is appropriate medically, it may not be appropriate based on your own personal beliefs. If we can make all those match, it can actually be a wonderful, wonderful thing that helps relieve symptoms and people feel better with. So communication, key. We have a lot of things in the pipeline. We're always trying to get better with what we do. Stem cells. We've been trying this for a long time. We're getting better. We're not there yet. But we would love to have things like stem cells or gene therapy to help really reverse the underlying problem. These are under trials, investigations. Maybe we have an investigational trial for you. So places like Ohio State and many of the other medical centers have clinical trials ongoing. Ask your care team if there is a clinical trial. And if you're interested in that, we'll get you the information. And if it's appropriate, we can get you into that to try to see if we can get those therapies earlier. But they do have to be proven. New medicines, new devices. We don't want to just put them in everybody right away because we want to make sure they help. We want to make sure we're not causing undue side effects or problems. So, hopefully some of these, if not all of them, will come to fruition and we'll have them available. Every year there's something new coming out. So that brings us to what to do when you come to that. Ask about those new therapies. But it's not just the physician, it's not just the nurses. There are a lot of people involved here, and you, again, are at the center of this. So we want you to really be the quarterback of your own care. So just to kind of terminology refresher, cardiologists such as myself, we have specialized training in heart and heart illnesses. That's what we work on. So you probably will get referred to a cardiologist. But that being said, your family doctor is still very, very important. Your family doctor is the main point of contact for many things, and we try to involve him or her, and hopefully you will do the same. Nurses and physician's assistants play a key role in helping manage the medications, blood work, test results, all of that. Pharmacists, I mentioned their role. Nutritionists, mentioned their role. This is what I wanted to get to. If you have an appointment coming up, what are the things that you can do to get the most out of your appointment? We want this to be a worthwhile visit, and we want you to walk away feeling comfortable with the plan. So come and tell us, how do you feel compared to normal? When is the last time you felt great? What is that not making you feel great if you're not? Be specific. That helps us. Have you had to decrease working or working out? The psychosocial aspects, the stress that this can cause at home is very real. Talk to us about that too. Your relationships, are they being strained? Are you having other issues at work with colleagues, and is it related to this? Again, maybe that's a side effect of a medication because you're feeling a little tired or loopy, and because of that you get grouchy. We can try to help you with that. But we don't want to ignore it. We talk a lot about the heart. The emotional well-being is very important. We do want to talk about all of that as well. There's a sample list at the website. You can use that as a template if you didn't write it down or can't remember. Again, the better prepared you are for your visit, the more you're going to be able to get out of it. And we want to make sure we're doing everything we can at those visits to treat, to address, to go over and come up with a care plan so that you walk out of that visit feeling comfortable. Because if you don't feel comfortable, you're not going to be able to be that quarterback of your own plan, and everything we're doing is going to fall apart. So a couple of tips. We already mentioned this, but this is important, so I'll just bring them up there again. The warning signs, the symptoms that you want to be careful about. Some of these can wait till the morning, but chest heaviness, really bad breathing difficulty, call in the middle of the night. There are ways to get a hold of people. An on-call physician, an emergency room physician if you need to do that. 911 if it's bad enough. Don't be afraid to utilize those resources that are available. If you come to see me, I may ask you to keep track of things medically, and hopefully it'll make sense now. Why? Why do we want you to check your blood pressures? Why do we want to check your heart rates? Well, if we think that this is affecting your heart failure, we want to know what's going on. We're only getting a little snapshot for about 20 minutes in the office. It's important for you to understand your own health, know what devices you have if something happens out there, the medical cards, medical IDs, things that you can communicate to others around you in the hopefully rare event of a medical emergency, but we know those can happen. The more information you can give, the better you can get treated. It's a daily process. You have to think about this every day. And every day, think about something you can do to make this a little bit better and make you a little bit better. And stick with it. And I mentioned patience is important. It's very important. But we can get better. It takes a little bit of time. Stay positive. It's easier said than done, I understand. And rely on those around you to really help. So involve your caregivers. Understand that this is stressful for them too, so work as a team, get that synergy working, and that'll help a lot. I mentioned this as well because it is important when dealing with any chronic illness, but think about forward planning. It's always better to think about certain things when you're feeling well, rather than doing it when you're feeling sick, because you're stressed, other things are going on, it's not the right time. So if you think it's appropriate, things like living wills and healthcare power of attorneys, bring them up at a visit once. Again, much easier to talk about when things aren't bad, because then you can have a fully informed discussion and enough time to think about those decisions. Tips for the caregivers, because I know not everybody in here has heart failure. Some are family members of heart failure patients. Hopefully you're doing this. You're educating yourself to help those around you, your loved ones. If you can, come to the medical appointments. Give us some information. Tell me when your other person's lying. It happens once in a while, right? Yeah, you got to bring your snitch with you. But two brains are always better than one. We work as a team even in the hospital, in the offices. You need to work as a team at home, so involve your team members. But if you are a caregiver, I would say, your job isn't to drop everything about yourself and just take care of your loved one. You can only take care of somebody else if you're taking care of yourself first. So it's a balance, again, working together, understanding where you're going to be able to provide that help and when you have to take time for yourself. Chances are you may have your own medical conditions. Make sure you're getting those addressed and taken care of. Get your own exercise, healthy diet. All of those things, it's important. It helps. I say it, again, easy to say, but it really does go a long way to helping people. So a couple of resources. The CardioSmart, here's the website. Encourage you to go to this to get a little bit more information or reiterate some of the stuff we talk about tonight. Mended Hearts, this is the Mended Hearts website. The American Heart Association also has a lot of great information there, and the National Heart and Blood, NHLBI, will have some information, particularly about clinical trials and other upcoming new developments if you're interested in that as well. So this is the Mended Hearts thing, some information again, or a phone number to get in touch. We would love to see you at more of these as well. So that being said, I want to thank you for coming. That's the bulk of my presentation. So hopefully you got some food, got your brain some food. And if everyone's okay, we'll actually maybe open it up now for a few questions.